All right, good morning, everyone. Thank you for joining us for this third installment of a five-part town hall series. Now is the time transformation toward equity, hosted by SPA 7 Integrated Community Health Coalition. So the purpose of this town hall series is to serve as a platform of engagement in addressing the global health pandemic and social justice issues relative to systemic inequities found across a number of items, including health, education, mental health and substance use, criminal justice system, and our housing system. Today's guest speakers are featured will be Bill Tarkanian, Director of Program Development, myself, Frank Nassari is Director of FSP and Peer, and Howard Padwa, Principal Investigator at UCLA. We look forward to hearing from them. A couple of housekeeping items. In terms of Town Hall Series agreement, in recognizing the level of stress and harm experienced by our communities, which may be enhanced by the difficulties in addressing these topics, we ask that you be mindful of the following, keeping in mind safety first for all participants and guests, recognizing that we may discuss difficult topics at times, and also to promote individuals' self-care, recognizing if you have any particular needs to log off or go off camera or what have you, to be sure to do that. The need for expressing sincerity and compassion to everyone participating and present for the Town Hall Series. Expressing a level of respect and patience for each other is also important. And making sure to hold each other in positive regard with respect to the material and topics that will be coming up. As part of our Zoom features, we have the chat option for folks to write messages or pose questions in the event that a speaker happens to be speaking, and those questions can be fielded appropriately. We have two individuals on our team that are monitoring the chat box, so please be sure to make good use of it therein. As mentioned, this town hall is going to focus on mental health and substance use. We thank you for your presence as we hope to hold discussions centered around equity at the local, community, systemic, and global level. Right? We want to celebrate successes and lessons learned. We want to be able to educate one another and create a safe virtual space for that exchange of information. And then we also want to offer solutions and promote movement toward resolution and accountability, which will be very important for our particular purposes here. First, I'd like to welcome in Bill Tarkanian, JD. Mr. Bill Tarkanian is a recovering attorney who serves as the Director of Program Development at Los Angeles Centers for Alcohol and Drug Abuse, LACADA, a community-based behavioral health nonprofit. Bill also concurrently serves as LACADA's Director of Client Engagement and Navigation Services, SENS, for SPA 7. Previously, he was Director of Outpatient and Community Services at LACADA, in addition to serving as a counselor and domestic violence facilitator and coordinator of the LA Homeless Project. Mr. Tarkanian is a certified addiction treatment counselor, a certified clinical supervisor, and a certified family systems specialist. He's a member of the National Association of Addiction Professionals and the Association of Battery Intervention Providers. Mr. Tarkanian holds a Juris Doctor, JD degree from Arizona State University College of Law. Before deciding to work in treatment, he was a civil and criminal trial attorney in state and federal court, specializing in sales and or possession of narcotics offenses. He earned his BA from Claremont McKenna College and a certificate in human services, alcohol, and other drugs from Los Angeles City College. Additionally, Mr. Tarkanian is an adjunct professor at Azusa Pacific University's APU Graduate School of Psychology. Bill is a fierce advocate for marginalized populations, including the homeless, LGBTQ, and systems impacted therein. Please join me in welcoming in Bill Tarkanian as he speaks regarding the equity and recovery-oriented care.
Thank you, Frank. I appreciate that. It's an honor to be part of this presentation, this work group. I appreciate everyone's great work and their commitment to health equity and restorative justice. I know I have a limited amount of time and a gift for gab, so I want to jump into it. And I will tell you, I'm hoping to share my screen here. That is the intent, right? I'm
Yes,
supposed,
please.
okay. Everyone see that?
Yes, you're good to go. Thank you.
Great, super. I proof positive that you can teach an old dog new tricks. So today's topic is the recovery-oriented system of care in the context of specifically with substance use and co-occurring disorders, in the context of a system that has historically relied on the criminal justice system and the inherent inequities. So I hope to tie both in together. If you'll bear with me, I'm going to go through some statistics that we all are probably familiar with and are upsetting, but I think they have to be repeated every time I share. It's necessary to remind people that we are where we are as a result of a failed war on drugs that started more than 40 years ago, and that those of us who work in the field of substance use disorders and mental health disorders largely have to overcome this system that's already in place that has criminalized these disorders by and large. So at any rate, that's kind of an overview of where we're going to be today, or what we're going to be talking about. So let's see here. Give me a second, guys. Okay. I assume most of you are familiar with LA CADA, and I don't want to waste too much time talking about the agency. I skipped over that slide. I just wanted to announce, if you don't know, that we're the proud recipients of a new contract through SAPC to be the community engagement and navigation service provider in SPA 7. And on the SUD side, that kind of makes us the lead for service provider area 7 in terms of screening and referrals, linkage and referrals into treatment. And our lean from LA CADA is our SEN supervisor. And I just wanted to, this is as of like July 7th, so it's relatively new. And I encourage people to keep that in mind when you're looking to link people into treatment. But as far as the topic of my presentation, I think we have to start with the startling fact that in 1980, just 40 years ago, there were approximately 860,000 Americans in prison or jail, on parole or probation. Today that number is in excess of 5 million. So in a matter of 40 years, we have seen this failed war on drugs feed the jails and prisons and then the people on parole and probation to a point where it has literally caused in certain jurisdictions like California systems to be actually under federal court supervision because we cannot provide adequate medical care or mental health care. Depending on the jurisdiction, most estimates place that 60 to 70% of all men and women in prison, jail, or on parole or probation with a diagnosable substance use or mental health disorder. And that's certainly true for LA County. Los Angeles County Jail is the largest mental health provider in the world. And in 2019, before the COVID pandemic, there were more than 17,000 men and women in Los Angeles County Jail, but only about 400 of them received treatment for their substance use disorder by virtue of the START in custody treatment programs, one at each of the 4 principal jails. And LA CADA was fortunate enough about 4 years ago to be selected to provide START in custody treatment at Men's Central Jail with a very specific and unique population, gay and bisexual men and trans women on the 9th floor. And it's been really one of the most rewarding experiences. But there are, on any given day, over 370 participants, or participants is not the right word, 370 persons incarcerated on that 9th floor, all falling within that category of gay or bisexual or gender non-conforming men and trans women. And at any given time, we were lucky to be able to treat 65 or 70 of them. The vast majority who wanted a treatment still didn't have access to treatment by virtue of lack of space and access to the persons incarcerated. The facts pertaining to the disparate impact of the criminal justice system on people of color is a sub-theme here. It's, obviously a relevant topic today in 2020. People of color make up approximately 30% of the United States population. Of course, it varies depending on your jurisdiction, but nationally, that's largely true. But they account for 60% of those incarcerated on probation or parole. 1 in 15 African American men and 1 in 35 Hispanic men are incarcerated, in comparison to just 1 in every 115 white men. This staggering statistic, 1 in 3 Black men can expect to go to prison in their lifetime. The war on drugs has been waged primarily in communities of color. According to the Human Rights Watch, people of color are no more likely to use or sell illegal drugs than white people, but they have considerably higher rates of arrest. African Americans comprise approximately 14% of regular drug users, but are 37% of those arrested for drug offenses. From 1980 to 2010, 1 in 3 of the 26 million people arrested for drugs was African American. Once convicted, Black and brown offenders receive longer sentences compared to white offenders, on the average 10% longer for the same crimes. People of color are 21% more likely to receive mandatory minimum sentences than white defendants, and are 20% more likely to be sentenced to prison as opposed to jail for the very same crime. And it doesn't just stop there. Voter laws prohibit people with felony convictions to vote, disproportionately impact men of color. Now, in California, felons are allowed to vote as long as they're not in prison or on parole, but this is not true in the vast majority of jurisdictions. So felony disenfranchisement is exaggerated by racial disparities in the criminal justice system, ultimately denying approximately 13% of African American men the right to vote. Evidence shows that spending time in prison also affects wage trajectories, with a disproportionate impact on people of color. Following a release from prison, wages grow at a approximately 21% slower rate than compared to white convicts. So even after release, it seems society is less forgiving to Black and brown persons in our communities. A criminal record can reduce the likelihood of a job offer by more than 50%, but the impact of a criminal record on men of color is twice what it is for white men. And then, it may seem out of place, but it isn't. Infectious diseases are highly concentrated in correction facilities. 15% of jail inmates and 22% of prisoners, compared to 5% of our general population in the United States, report having tuberculosis, hepatitis B or C, HIV or AIDS, and other STDs. There are various reasons for that, including the high number of substance users that are in jails and prisons, who would never be intravenous drug users on the outside, but are literally, that is the most efficient and most accessible way to use on the inside. And then there's also the unspoken trauma of prison and jail rape. These are realities that are hardly ever spoken about. I added this new slide because it's certainly relevant. In the current COVID-19 pandemic, no part of society has been more disproportionately impacted than our jails and prisons. At one point, it was estimated that as much as 40% of LA County's jail population was quarantined due to COVID. incidence of COVID infection inside the jails and prisons far outpaces society as a whole and has become a matter of life or death for those who are old or medically fragile. And I and other agencies have worked hard to seek early releases. We've done some really great work with the assistance of public defenders and other, well-intended people to get people, for example, with HIV or AIDS out of jail early, or older people out of jail early, people with immune deficiencies. So at any rate, that's just kind of a backdrop. And I just in case you didn't follow along, a failed war on drugs that disproportionately impacts Black and brown people or people of color, particularly Black and brown men. The extraordinary correlation between this war on drugs and the prison and jail population explosion that has resulted in somewhere between 2/3 to 3/4 of the jail and prison population having mental health or substance use disorders, largely untreated, and the relationship between the criminal justice system and people with mental health and substance use disorders. So, if they're fortunate enough to get out, not further traumatized, unlikely, or, worse than when they came in, which is what we see more often than not, and are still open to the prospect of seeking treatment or mandated into treatment, it speaks to the need for a recovery-oriented system of care, because it is this false notion that, and I'm going to speak specifically to substance use disorders, but I believe a substance use disorder, and I think most of the people at LA CAUTA believe a substance use disorder is a mental health disorder. It certainly is in the DSM-5. But this correlation between treating people with substance use disorders as though they're criminal defendants and not persons experiencing pain. My favorite author on the topic, Dr. Gabor Mate, and if you haven't read one of his books, I strongly recommend you read In the Realm of Hungry Ghosts. But Dr. Gabor Mate says the relevant question is not why the addiction, but why the pain, the emotional or physical pain that is untreated. And so if you continue to treat people with substance abuse and mental health disorders, as criminal defendants, what you're going to find is a system that is abstinence-based by and large, and it fails them as soon as they hit the gate and enter our communities. So what we need is a recovery-oriented system of care. And in my last 8 or 10 minutes, what I want to do is focus on what those principles of a recovery-oriented system of care. There's this false notion that you're either abstinence-based or harm reduction. I suggest that there's a whole sea in between. And this is what LA CAUTA, as one agency, and many other agencies are striving to achieve. So a recovery-oriented system of care would be client-centered or patient-centered, focused on the unique and individual aspects of the people we're serving. It's based upon choice and informed consent. Treatment should adapt to the needs of the individual rather than a one-size-fits-all program philosophy. And all the statistics show that it results in higher retention and better engagement in treatment. We have to treat addiction as a chronic disease. It's progressive if not treatable, treatable but not curable, relapsing, potentially fatal if not treated, and not an acute incident that somehow gets resolved by a state prison term, but a chronic condition that needs to be managed over a lifetime. The recovery-oriented system of care should involve a continuity or continuum of care that includes withdrawal management and then multiple levels of care, residential, intensive outpatient, and continuing support like recovery support services, so that an individual enters and then transitions up or down based upon medical necessity and not at some mandate of a judge, or for that matter, a social worker, a well-intended social worker who doesn't know anything other than what, their biases may be. The starting point is determined by a multidimensional holistic assessment, biopsychosocial assessment. There's no predetermined or fixed duration of care. It's based upon medical necessity. As a quick aside, we get to go into the courts all the time, and judges will say, I want him in your program for a year, and I'll say, well, Your Honor, if you can afford that program or find someone who will pay for it, we're happy to try to link them. The reality is, in today's system, we treat it as a medical model, and people are in care for as long as medically necessary. And because I used to be a lawyer, I'm comfortable saying it. Everyone else in the courtroom acts like I'm about ready to be taken into custody. But we have an obligation to inform the courts of what is true and what is not true. A recovery-oriented system of care should be strength-based. We focus way too much on people's weaknesses or faults, and so it's a partnership or a consultant model that focuses more on collaboration and less on hierarchy. Individuals should be empowered to direct their own recovery. It needs to be gender and culturally responsive. A recognition that beliefs and customs are diverse and impact outcomes is critical. Research shows that individuals in a more culturally congruent intervention were more involved in counseling sessions, more willing to self-disclose, more motivated to seek help, and more prepared to change. And we've seen that with our emphasis on LGBTQ programming as an example. Should be trauma informed because, as I referred to earlier, the relevant question is not why the addiction, it's why the pain. Incarceration is trauma, it's not treatment. Our friends on the mental health side are the ones who are most adept at doing trauma responsive care. But even in a substance use disorder setting, we should be trauma informed. We should recognize the trauma that affects every one of our patients who walks through the door. I'm almost through here, guys. There should be a commitment to peer support. Imagine that. We've gone all the way back around now to an emphasis on peer support. But peer support has been identified in the chronic care model as a method that is very effective in supporting patients in their illness and self-management. Research shows that seeing or visualizing those similar to oneself performing activities that are responsive to recovery typically increases one's belief in their own abilities. And I think I've got 2 more slides. We all need to be co-occurring capable. In other words, we need to be able to identify and at a minimum refer out to appropriate mental health providers, mental health disorders. The best of us are striving to be co-occurring enhanced, which means the treatment is integrated on-site, but at a minimum, we all need to be co-occurring capable. As I say, I believe substance use disorders is mental health, and we don't treat them separately, but we treat them conjointly. And this is, I think, the most important slide. Instead of abstinence as being the sole outcome, we need to look at other outcomes that are also extremely important. So if you were able to link someone to mental health and primary health, help them resolve their legal issues, they came in unemployed and now they're employed, or have access to education, they've re-engaged with their family, they've closed their DCFS case, and they're on track to getting permanent supportive housing, but the patient isn't abstinent. Have we not succeeded by and large in improving that person's life? The undue emphasis on abstinence has come at a horrible cost, and that cost is we don't look at all the other things we need to do to drive to help a person fulfill who they were meant to be. Our medical director, and I'll close with this, our medical director says that addiction is that one disease that when we get better, we don't just return to the point that we were before. We become the person we were always intended to be. We actually become better than we ever were. And I believe that. I'm a living, walking proof of that, and I see that every day. One last point, at some point in the treatment process, you get to involve family or allies. That's critical in helping people recover. And so the best programs have a family component to it as well, along with recovery support services or continued care. I don't know if I have time for questions, but I hope that this slide is made available for people. I know I rushed through it quickly. We really believe in a recovery-oriented system of care here at LA CAUTA, and I believe that those who buy into the false narrative that it's either abstinence-based or harm reduction should revisit that whole C in between, which is kind, caring, compassionate treatment delivered by professionals like who are participating in this event today. Thank you, guys.
Thank you very much, Bill. Does anyone have any questions for Bill that they'd like to pose? Or in fact, we could also field them at a later time during the chat feature. But thank you so much, Bill. I appreciate your strength in recovery and your capacity to be able to share that strength with others in the work that you do. Thank you so much. All right. For our next segment, we'll actually take a quick poll of those of us that are on this particular town hall. And our first question, you'll see it pop up on your screen. Go ahead and take a second to respond to. It indicates, please indicate any, all areas in your life that have been impacted by the COVID-19 pandemic. So if you would take a moment to submit your responses on screen, that'd be helpful. All right, great. Thank you. All right, now everyone's responded. Thank you so much for responding. Let's go ahead and take a look at what we've got with respect to those of us on this town hall. So it seems 87% would claim their work has been impacted, followed by family relations and mental health to close out the top three. So that's very, very helpful. We appreciate that, a bit of information. One more question to pose, and here we are. It asks, using the rating scale of 1 to 5, 1 being low, 5 being high, how well are you adhering to the recommended safety guidelines put out by the county? Go ahead and make your responses there. So there's hand washing, there's using sanitizer, physical distancing, etc. Wait for a couple more respondents. All right, great. Let's go and take a look at the results for this particular question. So it seems 86% of us are practicing physical distancing at a high level, which is great to hear. Wearing a mask as well at a level 5, and then also using hand sanitizer. So all of these are indeed great guidelines to follow and uphold as we've been instructed to do so, which will help mitigate the spread of the coronavirus. Very good. And since we're on a roll, I want to claim we're on a roll. One last question, let's field, and then we'll go to our next segment. So here's a question. Please indicate any and all sources where you are getting your information from. So is it news and traditional media, government officials, family and friends, or social media? Waiting for a couple more respondents. Great, thank you. All right, let's look at the results here. This was helpful as it gives us a sense of where information is being derived from. So news and traditional media is 43%, followed by government officials at 36%, which speaks to the fact of how much weight they carry in terms of the messaging and in terms of information that's put out to the public. So thank you so much. We'll go ahead and close out that segment of the polls. All right, thank you. Arlene?
Okay, so good morning, everyone. I am going to be introducing Dr. Frank Nasseri. Dr. Frank Nasseri serves as director of the Full Service Partnership Unit and the Powerful Initiatives for Early Recovery Unit in Mental Health Services at the Whole Child. As part of the leadership team, he represents the agency in networking with local organizations and contributes to the development and implementation of policies and procedures that drive field-based mental health services. Dr. Nasseri has been providing community-based and private sector services for over 20 years, having worked with all age groups from toddlers to geropsychiatric patients in various treatment settings, including private practice, homes, schools, hospital, PHP, IOP, and locked psychiatric facilities. Dr. Nasseri holds an APA accredited PsyD in clinical psychology from Argosy University, Orange County, where he taught master's and doctoral psychology students at an adjunct for 8 years, and is currently entering his 9th year of teaching as an adjunct professor at Antioch University, Culver City. His clinical dissertation was titled Post-Stroke Caregiving Assessment, Interventions, and Treatment Recommendations from the Biopsychosocial Perspective. Some of his areas of specialization include process improvement applications, staff education and development, policy and procedure revision, didactic training, lecturing, team building, clinical training and supervision, accreditation and conducting programmatic trend analysis studies. Next, Dr. Nasseri will be presenting a segment on mental health disparities. Dr. Nasseri?
Thank you very much, Charlie. Appreciate that. All right, let me now share another screen with everyone. All right, so with respect to mental health and the disparities therein, we're aiming to, oh, it's not even on the right one, there we are. All right, so we're looking to see the impact of COVID-19, of course, to the underlying inequities that a number of town halls have addressed and brought up in terms of the historical context and everything else. For this segment, we're aiming to shed the light on mental health, which is part of a larger system, of course, of everything else involved in the county. All right, so with that, the American Psychiatric Association, as well as the American Psychological Association, both dubbed APAs, have already highlighted mental health disparities across different populations and groups. And these are research and articles that can be found. And here I've just aimed to provide short, sharp points to draw your attention to the disparities that are contained within these research findings. The first one on the left reads, only 1 in 3 African Americans who need mental health care receives it. And that's a powerful point to mention. And with respect to the African American population, turns out that when compared to white populations, those with the same symptom presentation, if and when they're African American, they happen to be diagnosed with schizophrenia as opposed to a mood condition or mood disorder as their counterpart, white counterpart. So that's an interesting, again, another disparity and something to be looked into. With respect to Asian Americans and Pacific Islanders, they're 3 times less likely to access mental health services than their white counterparts, which makes it, again, another point of discussion and attention to be drawn. On the side where it indicates American Indians and Alaska Natives, mental health services utilization rates for American Indians and Alaska Natives are low. And the combination of factors that contribute to it are stigmatization of mental health, lack of culturally trained providers, and lack of available services. And lastly, but not least, the Hispanic and Latinos mentioned here. Approximately 1 in 10 Hispanics with a mental health disorder use mental health services from a general healthcare provider, while only 1 in 20 receive such services from a mental health specialist. So it speaks to the specialization needed for addressing certain conditions for populations. Here, with respect to the barriers to care that are highlighted across these research articles, the aggregate and variably, the items on the left point to what are the common and cross population barriers, right? Stigma associated with mental illness, the lack of providers from diverse racial ethnic backgrounds, the cultural component competencies of providers, lack of knowledge and awareness about mental health problems, and lack of appropriate intervention strategies, including integration of mental health and primary care health services. And then lastly, often mental illness is considered a weakness and a source of shame or burden among the community. So by and large, a number of the populations mentioned here are impacted by virtue of these items as barriers that are preventing care or stand in the way of adequate care, all right? Another cross-section to look at in terms of the research out there of mental health disparities for LGBTQ, it finds that LGBTQ individuals are 2.5 times more likely to experience depression, anxiety, and substance misuse compared to heterosexual individuals, all right? And with that, for gay men, most common causes of depression are prejudice events, expectations of rejection and discrimination, concealment of identity, and internalized homophobia when gay populations were looked at in terms of mental health facts. And then over on the right, as a subpopulation of bisexual populations, it indicates that the risk of suicide in bisexual populations is higher than that of heterosexuals, gay and lesbian individuals. So the point being, we really want to make sure that we take into account the nuances of every particular population group. And on the bottom right, it indicates questioning in queer populations. Turns out the rate of suicide attempts is 4 times greater for lesbian, gay, and bisexual youth, and 2 times greater for questioning youth than that of the heterosexual youth. And similar to the last research findings, the barriers to care indicate, again, variably across these studies, that the health disparities among LGBTQ people are linked to stigma and discrimination, right? Lack of federal employment, non-discrimination protections for LGBTQ individuals. The concept of internalized homonegativity refers to the direction of negative social attitudes about homosexuality toward the self, which lead to a devaluation of the self and poor self-regard. And then also patients report dissatisfaction when a clinician acts judgmental of same-sex activity or wherein they maintain anti-gay attitudes and or display a lack of knowledge around health concerns specific to the gay community. And the last point there, that's asterisk, the outcomes depend on how the healthcare provider responds. I'll repeat, the outcomes they found depend on how the healthcare provider responds. And that's an important piece to take into consideration if we are, again, intending to be mental health heroes for populations that are really have disparities found amongst them. According to the American Psychological Associations, their recommendations happen to center around facilitating partnerships across multidisciplinary teams and groups and individuals, right? Educators, community leaders, government officials, et cetera. And the point to the bottom of it is the recommendations foster positive relationships and programs within racial and ethnic minority communities such that it increases awareness of mental illness and prevents environmental factors that may place individuals at risk. And so we've heard earlier from Bill in terms of things that are factors that contribute to, pose risk factors, I should say, to various populations. On the right, it indicates to develop and implement policy and programs, of course, based on psychological and behavioral research. And that's important because if we look at right now, research that's been conducted, these are long-term longitudinal studies that are very, very important, which tells us it's not new. It didn't happen overnight. So we want to take that into consideration when we say that there are disparities, there are vulnerabilities, there are inequities. They've been there for quite some time. And a number of the town halls have spoken to that in terms of the historical context is provided. Last point there, it indicates that we should be an advocate for local, state, and national funding agencies to incorporate culturally and linguistically competent guidelines into proposal for programs in racial, ethnic minority children, youth, and families. So across the board is really what's intended there. All right. Now, one of the things that came up as we were conducting these town halls was the scope or scale of the problem, if you will. And so on the mental health side, when I attended a lecture on ecological systems approach, I use the word ubiquitous on purpose. It's a $10 word. It's pretty heavy, but I do it on purpose so that the first two letters, the U and the B, can remind folks of who the whose model it was. Actually, it's Uri Bronfenbrenner on the bottom. So, and the term ubiquitous means everywhere and involving everything, if you will. So from this approach, on the lower end of the scale down here, if you will, if you look at it, it describes the teen or this inner layer where gender-based roles and behaviors, racial and ethnic identity come into play, and biological and genetic makeup is determined or at least at play. From this level, it branches into the microsystem, or a second layer, as it may be dubbed, around the interpersonal dynamics, or parenting style, peer influence, social connectedness, and what are called adverse childhood experiences. Larger than that, we go into the exosystem of neighborhood and the community by large, and school policies and employment and workforce and mass social media, which speaks to a more broader spectrum. Finally, leading into the macro system of the model, where cultural values, ethnic and racial health beliefs, ideological political positions on national issues, and unexpected environmental changes can impact the entire world, if you will. Okay. Now, this was, of course, a model that, you know, I had lectured on over and over and over again. But in recent times, what we've found is that there's some parallels exactly to this ecological approach, wherein we find that down here on the inner layer, for the individuals that are protesting and what's going on for them, the gender, the racial identity, ethnic, all of it has come to surface, of course, of late with the Black Lives Matter movements and various traumatic events that have occurred. As the second layer here, the parallels are how are we interacting with one another, right? Here, the model speaks to social connectedness, and yet right now, we're being asked to socially distance and how to navigate and operate in that manner, right? On the ecosystem level, well, the schools were a very important piece of that structure, and now they're closed, and it's unknown in terms of when they'll reopen and how they'll reopen, of course. Of course, in this realm is the employment and work force. That's impacted, obviously. And note here that the pandemic, of course, has really all over the world as it parallels the impact we've seen all across the world, okay? So this is intended to, again, in a pictorial manner, get us to wake up and recognize and be mindful of what's always been there, right? The models have always been there. It's really something that draws our attention yet again to the importance of making sure that everyone and everything is impacted, and there's histories to all these impacts, right? Now, in looking at the public health efforts, right? And so from previous town halls, I learned quite a bit, and it led me to investigate a couple of things, one of which was finding that California had the first inaugural Surgeon General, meaning the first ever appointed Surgeon General, Dr. Nadine Burke Harris, right? And very, very fantastic speaker. You can find her on TED Talks, TED Med, where she talks about her involvement and use of what's called the ACEs measure, okay? And I purposefully left the date here of March 6, 2020, and that's the video clip here that at UC San Francisco, a lecture was held on that day, and shortly right after that, if you recall, a lot of lockdown procedures were ordered by the county. So right before the lockdown, this lecture was held, and wherein she describes this measure, and it highlights actually an important piece of the puzzle that, again, I'll say it, it's been there for quite some time, but now we are, it behooves us to pay attention to again. And what it lists is the prevalence, all right, and the associations of death according to heart disease, cancer, accidents in the adult based on something important. And that something important is what's called the adverse childhood experiences. Okay, and if you remember, it was in the Brunford-Brummers model, all right? But now pulling it apart, we see, wait a minute, our own Surgeon General has spoken to this, right? And so the original article looked at the relationship of childhood abuse and household dysfunction to many of the leading causes of death in adults, all right? And so it was a joint partnership between the Centers for Disease Control and Kaiser, where they looked at the relationship of health risk behavior and disease in adulthood to the breadth of exposure to childhood emotional, physical, or sexual abuse and household dysfunction during childhood, right? And for quick reference, I itemized and highlighted the key points that the measure looks at, right? In terms of abuse, right? They look and investigate psychological abuse, physical abuse, sexual abuse. And as an example, the two out of the 4 questions for that instrument asks, did an adult or person at least 5 years older ever touch or fondle you in a sexual way? Or have you touched their body in a sexual way? So these are sample questions to that measure. With respect to the household dysfunction domain, they look at substance abuse, mental illness, and the 2 examples there are, was a household member depressed or mentally ill, and did a household member attempt suicide? And another component is mother treated violently and criminal behavior in the household. So keeping in mind that these components or categories of childhood exposure to these items increase the risk of health complications as an adult. Now it highlights the importance of, if we are working with populations right now, and they're in the midst of these exposures or these complications or these experiences, then we have a duty, if you will, to safeguard them as best we can so that they don't develop and contribute to those problems, okay? All right. Now, with that said, of course, and Bill rightly brought it up in terms of trauma-informed care, et cetera, it's a very critical component to our training and to our service rendering, which is great. And in that sense, if we look at trauma across the lifespan, so chances are, as service providers, we may be working with individuals from 0 to 5 over on the left, all the way up to teens and adults and older populations. So to really account for and appreciate the breadth of individuals we may encounter, right? And as a quick reference, right, the 10 key ingredients for trauma-informed care is mentioned here, and it describes what trauma is and how many different ways it can be taken in or considered. And then what is the impact of trauma on health? And that's where actually the instrument is mentioned again. So the adverse childhood experiences study, right? So looking at and finding all the interconnected pieces of something that's really global and ubiquitous, as we said, to the care that we're looking to provide. And so how can providers become trauma informed? And as Bill put it, trauma responsive strategies and care is very, very important, and it's interconnected, ultimately interconnected, and that's the important piece we're looking to communicate, okay? All right. With that, the Journal of American Medical Association most recently, all right, put out the latest information or publications, if you will, around coronavirus and how it impacts children and adolescents. And again, I've provided you with the reference directly here and pulled out and extracted the short and sharp points therein. And it really speaks to the importance of, hey, what is the impact of the current experience of COVID-19 to children and adolescents, right? And recognizing that, you know, mental health disorders begin in childhood, of course, making it essential that it's identified early and treated as such is very important. Looking at the economic downturns as they're associated with increased mental health problems for youth, and that they may be affected by the ways the economic downturns affect adult employment, adult mental health, and child maltreatment. Okay, very important. So it's a very comprehensive look at and accountability for the interconnectedness of things, right?
Frank,
Yes.
we have a question before you move on. Is that okay?
Yes, please. Yes.
The question was, does the criminal behavior in household category, this is back to the ACE study,
Yes.
for siblings engaging in criminal behavior, or does that just apply to caregivers and parents?
So according to the measure, all right, so the adverse childhood experiences measure, it was as an adult when they're surveyed and covering the period of when the adult was a child. So the parental figure or anyone being incarcerated. Now that may expand to siblings being incarcerated if it was during their childhood, yes. All right, so the impact of incarceration to the family unit, if you will, yes.
So pretty much anybody living in the household, you know.
Yes, yes. All right, a great, good point to bring up, yeah. All right. The point down here in terms of school closures, all right, and it indicates that the latest opinion is that school closures will be relatively more disruptive for the mental health care of some youths, keeping in mind that school happened to be a place where a lot of them got mental health services, had access to counselors and teachers and people who can actually keep an eye on them and help them out, right? And so adolescents and racial and ethnic minority groups with lower family income or with public health insurance were disproportionately likely to receive mental health services exclusively from school settings. Already they were at a disadvantage, now further and compounded disadvantage the fact that schools are not open right now or accessible, okay? Looking at the next segment in terms of the pandemic's impact on populations with serious mental illness, okay? So again, in real time, as of April 2020, all right? Of course, there's no vaccine or treatment in sight yet, but we also have to look at the contingencies and the impact of chronic conditions and to do the best we can to at least address them to the capacity we're able to. The second item indicates that it is important to address the psychological and social dimensions of this epidemic for patients. Worry could both exacerbate and be exacerbated by existing anxiety and depressive symptoms. So keeping in mind that the additional layer of COVID-19, the pandemic, adding to and exacerbating the pre-existing conditions and complications. And keeping in mind the physical distancing strategies, although they're critical for mitigating the spread, they may also increase the risk of loneliness and isolation for folks, all right? Keeping in mind that social connectedness was part of that ecological system approach. So those who become ill may face dual stigma, one of them associated with their infection and their mental health condition. So we want to be mindful of that as well, all right? And then for any given patient, psychological symptoms will emerge in a unique personal and social context that should be looked at and considered in developing a treatment plan, all right? Very, very important, all right? And I'll speak to that in a little bit. Last point regarding the Journal of American Medical Association is how, more specifically, physical distancing has impacted folks. And again, past this prologue, I'll repeat, right? So we've had other traumatic instances, large scale, the World Trade Center attacks and mass shootings, and natural ones of hurricanes, and environmental ones was the Deepwater Horizon oil spill. They're almost always accompanied by increases in depression, PTSD, substance use disorder, a broad range of mental and behavioral disorders, domestic violence, and child abuse, okay? So from there, this particular article provided 3 points or directives, if you will, that they adopted from the mental health system of United Kingdom. The first one being it is necessary to plan for the inevitability of loneliness and its sequela as populations physically and socially isolate, and to develop ways to intervene. Secondly, it is critical that we have in place mechanisms of surveillance, reporting, and intervention, particularly when it comes to domestic violence and child abuse. Now, this point I want to underscore. In terms of surveillance, what that really means is when the kids are at school, there's monitoring, there's an eye on them from the teacher, from the person who's out in the yard, et cetera, from the cafeteria person, whomever can actually keep an eye on the kid and look for differences in their behavior or whatnot. We don't have that right now, right? If we don't get them on the phone, or if we don't have them through a virtual video conference, we don't see them, all right? And we can't really account for what's going on in the home. That's a very important and relevant point to be able to address, okay? And of course, the third item being the telemedicine, mental health visits, group visits, and delivery of care via technology platforms will be important components of step care for both acute crisis management and more routine communication and support. And so what that suggests is, however we're doing it in the virtual sense, we really need to make good use of that platform for the intended purposes and availability to, again, address these disparities already in place, okay? Now, closing out, what can be gleaned from all of it in real time? Give me some tips for clinical practice. One of it would be encouragement to revise our mental health service approach, having learned from it and accounting for the disparity and vulnerability identified. We'll need to calibrate. Calibrating of the service scale will be needed, right? Bill also talked about that goodness of fit. Here we go again. We want to make sure, hey, one size does not fit all. We want to recalibrate that. We want to look at that again in terms of our service approach, service interventions, and the needs of the service recipient is very important. If, for example, we're clinicians and we have an individual caseload and we only treated via individual therapy, well, now we want to and need to take into account and integrate collateral sessions with the parent, with the caregiver, with whomever, all right, to enhance our sense of filling in the gaps, as we would say, in terms of conducting a gap analysis to say, okay, what's missing, what's not there. And the pictorial on the right, I should mention, is another way of looking at the ecosystemic approach to say, hey, all these places and different things, they're no longer operating, right? And so we don't have access, we don't have the means of gauging folks' social interactions and capacity to maintain their daily activities. And then on the bottom, I should also point out, I found it pretty funny to find this clip. It said, I'm a mental health worker. To save time, let's just assume I'm always right? And we have to really take that into account, that folks do look upon us as care providers, service providers, with that level of having some capacity and competency. So we really need to deliver on that. To that point, I would offer that we overtly integrate COVID-19 and its impact to our services. And here we go again, the biopsychosocial context. So what are the physical and health and disease complications that our population is suffering from, and how can we best contain that? How can we provide that level of containment? Similarly, in terms of their psychological and emotional well-being, how can we best provide containment for that? And then the third component, the social interpersonal challenges and differences and changes that folks have had to endure. How do we provide containment around that? And the last point there indicates the service provider to service recipient. As much as we do put our effort towards client care, we also have to set aside time for self-care, which is very important as well, all right? And whether it's for our clients or for ourselves, we really want to employ you to approach your work, your life daily with unconditional regard, right? For the sake of all humanity in that regard. All right, last point, we'll bring up a couple pieces in terms of our access to care. I would encourage us to make some enhancements with respect to what are the determinants of mental health services that we used to have, that they had to meet certain criteria to receive mental health services. Hopefully right now, in terms of policy reform and legislation, I know as of June 29, 2020, Congress had submitted a letter to revise the guidelines for telemedicine in terms of place of origin, site, and all that, to say, hey, let's remove that restriction. So all these things that are happening because we want to make sure that a lot more individuals receive mental health services that potentially before they didn't have access to. And I promote us shifting our mindset and perspective from field-based to virtual-based as appropriate, right? We have to really set into practice new behaviors, new strategies, new interventions in the virtual sense, right? And humorously, if we could look in Darwin's Handbook for Survival, because as it says, right, survival of the fittest, we really want to be able to survive through this pandemic, but also really thrive at the other end of it, right? And This speaks to our survival, your survival, my survival, a community's survival, a program's survival, et cetera. So how can we best assure that the right work is being done and that it really stands the test of time and really helps us through this? The point in the bio, if you recall, about my dissertation project, I kept that in there because of really importance of caregiver burden and caregiver stress, okay? So let's be mindful in our service planning around that, right? Abruptly, folks have had to take on the role of caregiver because of COVID-19, right? But keep in mind, pre-COVID, they were caregivers in one capacity or another. And that research found that 68%, by virtue of being a caregiver alone, increased mortality rate of 68%. So we really want to, again, take that into consideration. And the last 2 points, pandemic-informed risk assessment, all right? Let's be, again, overt about it. During the pandemic, what is a pandemic telling us in terms of how to revise our risk assessments? Increased level of suicidality is going on. There's isolation. There's the online vulnerability we have to account for. Family dynamics that may have shifted. Substance use and stress tolerance, right? So all these components that I'm hoping that we can integrate in our revamping of our risk assessments. And then lastly, the staff training and supervision practices really need to revise the training and supervision competencies so that they speak to really what is going on. And again, include initiatives and interventions that will see us through the coming times, okay? And with that, it's really with the admiration that we say mental health heroes. And I learned this from a previous town hall from Jose Smith, and I kind of revise it to say mental health heroes serve out of commitment, not out of convenience, right? And so that's really important. So because we are the stakeholders or the gatekeepers of service and share that responsibility, what is our level of commitment? What can we do? How can we join together and really make a difference? Any questions around that? No?
Hi, Frank, this is Cecilia. I have a question on, is there any resources or any guidance or tips that you would like to share or can on supervision, the last point that you made as to adjusting supervision during this time?
Yes, and so there's a lot of trainings that the LA County has put out, also PHMP with collaboration with UCLA, a group that has put trainings out. It's there, we just need to increase the volume and frequency of those trainings, but they're there. And again, I'll be more than happy to forward that to you, Cecilia, with at least respect to those that are up and coming. And I think it'd be worthwhile for folks to connect on and register for. Absolutely though, yeah.
Thank you.
Sure. All right, great. And again, you're welcome to continue questions in the chat feature as we go back to our particular case. So now the next component, we'll do a quick polling and then we'll reach out to our third speaker. Okay. So now let's look at here. Stop share results. All right, here we go. So let's look at our fourth question. I'm going to launch it now. All right, so using the rating scales 1 to 5, 1 a little, 5 being a lot, based on individually following the county health code order regarding COVID-19 safety practices, how safe do you feel from contracting COVID-19? A little, somewhat, enough, or moderate? Go ahead and please make your selection. All right, great. Thank you. All right, so let's look at the results therein. Majority of us, 43 and 43, feel somewhat and enough protected from contracting COVID. That's good. All right. Good. Let's go to our next question and then we'll move to our next speaker. All right, this question asks, using the rating scale of 1 to 5, 1 a little, 5 a lot, based on others following the county health order regarding COVID-19 safety practices, how safe do you feel from contracting COVID-19? So this is in response to others following the directives. All right, interesting. Okay, great. So now let's look at the results here. So 50% of us feel somewhat safe with respect to what others are doing in their behavior, and followed by 36% feeling a little. All right, so that's very telling, and I appreciate everybody's participation in the polling. So let's go ahead and move forward. All right, next, we'd like to introduce in Howard Padua, PhD. Dr. Howard Padua serves as principal investigator at UCLA's Integrated Substance Abuse Program, UCLA ISAP. He has led qualitative data collection and analysis for mixed method studies on mental health service, mental health system transformation, behavioral health services integration, evidence-based practice implementation, and the creation of a full continuum of care for substance use disorder treatment under California's Drug Medi-Cal Organized Delivery System, MDC ODS, Medicaid 1115 waiver. Currently, Dr. Padua is leading several evaluations of initiatives to provide integrated services for homeless and other populations in Los Angeles, and he is co-investigator on a PCORI-funded study examining substance use disorder treatment, assessment, and decision-making. Dr. Padua holds a PhD degree in history from the University of California, Los Angeles, UCLA, and an MA degree in history, as well as a BA degree in history, French political science from University of Delaware. Dr. Padua has been cited as co-author in over 13 journal publications, including the latest titled, Translating Science to Practice, Lessons Learned, Implementing Evidence-Based Treatments in U.S. Substance Use Disorder Treatment Programs, European Journal of Criminal Policy and Research 2018. Please join me in welcoming in Dr. Padua as he speaks about the equity and youth-centered treatment approach.
Hi, everybody. Thanks so much for having me, and sorry to have just be signing on now. Frank, should I go ahead and share my screen?
Yes, please.
Okay, let me pull up my screen. So really appreciate the chance to speak with everybody today. So what I'm going to be talking about today is an initiative that me and my colleague Sherry Larkins at UCLA have been doing with Rachel Castaneda and Irene Valdovinos from Azusa Pacific University in partnership with the California Community Foundation, working with Jeff Farber, who's here on this call, and his group, looking at issues of the youth system of care for substance use disorders in Los Angeles County, and particularly thinking about how to make the system one that's truly youth-centered. And I'll talk a little bit about it in the presentation what this means. Also, if people have questions or comments throughout the presentation, feel free to ask via chat, or you can send a quick message to Frank or Jeff and they'll let me know, or just even chime in. So thinking about our community and the issue of substance use disorder treatment overall, it's particularly important for youth because, as we know, in the short term, in the immediate substance use, it increases risk for all sorts of not good things. Risk for disciplinary problems, poor educational outcomes, justice involvement. And there's particularly high risk of negative consequences for youth of color due to issues of social equity and disparities. So beyond the medical piece of it, there's also the social and kind of political aspects of this, where substance use can really get a kid's life on the wrong track. So it's something that needs to be addressed in that way. However, the other area that's been the focus of a lot of research recently has been more on the side of the actual health impacts. One thing that we know, and as you know, as people who may work with youth, is that youth are not just mini adults. Their brains are actually different and continue developing into the early to mid-20s, particularly in the prefrontal cortex area that controls a lot of things about decision-making and impulse control. So substance use during this time, the impacts of these chemicals in the brain can actually impact the formation of the circuitry and the formation of these brain structures. And as a result, it can have consequences that aren't just a matter of a youth's behavior today, but lifelong impacts on cognitive and psychosocial achievement moving forward. So given that, and given everything we know about how substance use among youth is kind of a high risk, such a high risk area, we know that investing in substance use treatment for youth can really be one of the best bang for the buck things we can do. One of the best ways to promote both short-term health and well-being and long-term health and well-being for youth, because of the fact that it can keep them out of trouble and issues with addiction in the short term, but also really help them avoid a lot of the downstream consequences that could come not just from substance use, but also from the consequences that substance use can have on brain development. Now, overall in the research world, we've developed a pretty good sense of what works in terms of youth substance use treatment. If we could just put youth in a lab and do all of our interventions with perfect fidelity, we'd be in great shape. However, we're not always able to provide them. So we need to ensure that we're able to provide them in the real world and ensure that these services really reach the youth who need them. Now, this in many respects is really a missed opportunity for us. We know based on the National Survey of Drug Use and Health, which is kind of the most reliable national survey looking at these issues, that about 4% of adolescents and 15% of young adults need specialty treatment. However, just under 14% of them receive it. And the issue isn't just that they don't receive care, but that even when they do, the care isn't particularly good or well matched for what youth may need. Unlike the adults system of care, where we can talk about a system of care. I logged on late, but I saw a little bit earlier with one of the speakers speaking about the need for a continuum of care, residential through intensive outpatient and outpatient, et cetera. We don't really have something like that for youth. What we have are rather some adult programs have youth services as an add-on. That's generally the rule for youth SUD services. And then there are also a lot of programs that are youth serving in general in terms of providing mental health and other services that also develop substance use capacities. Now, this is a real problem from the policy level, particularly when we say we have this great adult substance use provider, they're experts in substance use, why don't we just have them do youth? Because it's the same issue. But because of the issues with brain development and other things, it's not like saying, oh, we have a great cardiovascular expert who's good at adults, they can treat youth cardiovascular issues. The needs of youth when it comes to substance use disorders and treatment is very, very different. One main thing, obviously, as mentioned earlier, is that youth are in very different stages in their development, both in terms of brain development and also just their life. Another thing that we've seen is when programs just say, let's bring some kids into our adult program, there's this risk of what we call negative adult influence, and that there's a lot of potential vulnerability sticking a 15-year-old in a group with a bunch of 30-year-olds in terms of the negative influence that they could have. Also, often program staff in adult serving programs often aren't really used to working with youth. They are used to working with people whose experiences are much more intense in terms of their substance use history. People who have been using for 15, 20 years are generally the kinds of folks who wind up in adult treatment. And obviously most youth have been using for maybe 2 to 5 years. So very different youth histories and needs as well. Now, as a result of that, youth often don't have as much acuity in terms of their substance use, but also they're not motivated to seek treatment for the same reason. Often for youth, it's a matter of, why are you here? Because I got in trouble or because I got caught. Whereas when we look at adults, yes, certainly coercion plays a role, but also a lot of people who are in adult treatment have seen substance use cause a lot of damage in their lives in terms of making them go to jail, losing kids, losing relationships, things like that. Kids haven't gone through that with substance use yet. They're told that this will happen, but they haven't faced these consequences. So as a result, their motivation is going to be very different because of the fact that they haven't really experienced the damage in the same way. And as a result, they're going to respond to different kinds of interventions. An intervention that says, take an inventory of substance use's impact of your life may work well for a 35-year-old who's lost their kids because of their substance use. For a 16-year-old who's just been told to go to treatment but hasn't suffered any other consequences, that kind of intervention isn't going to motivate them in the same way. So we need to make services that are really more youth-specific and focused. So within this context, as you all know, and I think maybe it was mentioned earlier, California launched its Drug Medi-Cal Organized Delivery System, which is the Drug Medi-Cal waiver, to improve access and enhance the quality of SUD treatment for all Californians. However, if you look at the waiver, it's kind of like how I was describing the system, the youth system overall before. It's about the adult system, and they say, yeah, let's do this for youth too. It's not really youth tailored. Then this map here is taking a look at SPA 7. There are 6 organizations across 7 locations that provide drug Medi-Cal services, which really isn't very much. Now, particularly troubling is that youth need these specific kind of services. There are very few programs that provide it. And these programs are really financially at risk. A lot of this is because back a few years ago when there was the scandal with drug Medi-Cal fraud, a lot of the fraud was among programs that were youth programs. As a result, they're under a lot of scrutiny, and it's made it difficult for them to adapt to a lot of the administrative and financial requirements of the waiver in order to continue providing services. Also, COVID has been really hard. In particular, I mean, this has been across the board. COVID's been hard for providers, but particularly for youth providers, because where do youth providers get their clients? From schools. And it's not necessarily from schools in terms of telehealth, but it's in terms of where schools when children are physically there, when youth are physically there. We haven't had that, therefore referrals have been drying up. And based on a survey we did, over half of the youth providers in LA County face imminent risk of closure due to financial problems caused by COVID-19. So this is an area that's critically important. We had a system that was already grossly underdeveloped, and it's a system that kind of, COVID has exposed all the warts and weaknesses across society. Here as well, it's a system that's very vulnerable, and COVID has really exacerbated that. So with all of this in mind, our group at UCLA has partnered with Azusa Pacific and the California Community Foundation to work with the Youth Services Policy Group, which is a group of youth providers here in LA, to see what are the shortcomings in the Medi-Cal system of care for youth, particularly youth from underserved communities and communities of color. And then also, rather than just cataloging everything that's wrong, let's think about what would it look like if it was right. So a lot of what we've done is a lot of people in the youth services group are really leaders and innovators in the county. So looking at this question of what would a youth-centered system of care look like? Rather than just focusing on this question of woe is me, there's all this stuff we need. Let's say we were given a blank check tomorrow. What would we do? No one's really, that hasn't been thought about very much. So this is something that our group has focused on. And hopefully that at the local level, we can think about as well, where even if the state can't necessarily start creating this, we as communities, as service planning areas, can start moving in this direction of, for our own communities, having a youth-centered system of care. And also part of what we're thinking about is how do we translate this vision into reality, especially in the era of COVID. Are there any questions or comments so far? Frank, I'm gonna trust you to kind of let me know if anything comes up, if that's okay. So how have we been doing this? Well, we've been working with youth providers quite a bit lately. Through the Youth Services Policy Group, we've facilitated discussions and had some structured brainstorming with policymakers, including LA County and DHCS staff. We've had interviews with youth service providers and key stakeholders from across the county. Also, something we did is, since we're talking about youth, let's actually ask them what they think. we were able to partner with the LA Trust to actually interview a bunch of youth to talk about, from your perspective, what is it that works? What doesn't? What is it that these adults we're talking to who only have the perspective of service providers may be missing? And then we did our survey that I mentioned of the impact of COVID. And throughout this process, we've been issuing data briefs and reports to help inform communities, providers, and policymakers across LA in partnership with the foundation. Oops, I hit the wrong button there. So what should youth services look like? Again, we have a blank check. Let's say we're in a perfect world. What's it gonna look like? Well, one thing it's gonna look like is it's gonna have a lot of outreach, particularly because of the fact that, as I mentioned earlier, youth aren't necessarily going to come to treatment out of their own motivation right away. You need to have outreach to help facilitate engagement. So what would that look like? Well, as with everything, you got to go where they're at. So have outreach to places that serve youth: schools, health centers, churches, rec centers, places like that. And also there's a need to shift strategies due to COVID, because of the fact that normally this is what we would have done, but people aren't going anywhere these days. So we have to reach out to families. We have to find ways to advertise through social and traditional media platforms. And also we need to focus outreach on educating youth about the services that are available and try to reduce the stigma around substance use, because a lot of people don't even know that county services are available. Another thing is when you hear PSAs and things like that, they talk about treatment is available, help is available in the substance use field in general. One thing we've learned is that prevention, education, treatment, that doesn't exactly make kids excited about coming in for treatment. So one thing that's really important is language, and thinking about coming up with words that are enticing, and also tailoring our messages. In particular, tailoring our messages to different youth. Just like all adults are not the same, a mistake that we've often made is that we think that, well, there's a message to appeal to youth, as if youth are a monolith across geography, across race, class, gender, etc. And one thing we heard, particularly from the youth, is, you know, if I'm a kid who's in high school and I'm a B+ student and I'm about to graduate, what's going to bring me into treatment is going to be very different from the youth who's currently homeless and worried about where their next meal is going to come from. So a lot of our engagement needs to focus on those different things. For those with more immediate needs related to survival and health, focus on that. Maybe for the kids who are in better situations or less precarious situations, think about, well, what are things we can do to help promote your long-term well-being, helping you get a job, things like that. And then also a big challenge that the field faces is that normally we begin rapport building once someone comes into treatment. That's when you start really working with them and getting to know them. However, one thing that we've learned is that kids aren't going to come in unless the rapport is already there. So we need to have a lot of informal outreach and a lot of work to enhance motivation before actually starting treatment. Now, this is something that's very hard because of the fact that there's this concern about paying for services for someone who's not necessarily enrolled as a client. Yes, we have that as outreach and engagement, but there needs to be a lot of that in the field and flexibility to be able to do that. And that's something that creates a policy challenge, particularly if we want to think of engagement as the first step of treatment before youth have even entered treatment. So it requires a shift in the mindset. Also getting at the question of, so we're talking about treatment, what should it look like? These are some of the things. Create spaces that are fun and appealing, use incentives to promote participation, transportation, have services that are field-based, because for kids, it's much easier to meet at a Starbucks in their community than have to take a bus across town. Help finding community-based support, and care coordination and case management to address the whole person rather than just their substance use needs. Now, the other thing that's been really neat about this process, talking to providers and youth, is getting at this question of how is youth services different? What are the specific things we need to do that are different from the adult model? So we have some of them, but here are some other things we came up with. One is we need engagement to be much more friendly. As I talked about, allowing time to build rapport and trust. One thing people told us is that, for an adult who's come in and has had a lot of problems, they're willing to, spill their guts on the first day. Kids, for the first 3 weeks you meet with them, you ask them, how you doing? They'll say, I'm fine. It takes time to build rapport. It takes time to build trust. And it's something that we as a system, if we say, we want 60 days of treatment, but it takes 55 days for the kid to actually start opening up, that's a problem. So that's something we need to think about. And also we need assessments to be briefer and more engaging. In the adult system, under these Medicaid reforms, clients are required to undergo an assessment when they enter treatment that's really holistic and gets at their whole picture. And an assessment that takes about 2 to 3 hours, very hard to get a kid to sit through that. And if they do sit through it, not likely they're going to want to come back, because that's not really a good first taste. So we need to make treatment more engaging from the start. Also, a couple of things clinically is that compared to the adult model, kids need a lot more opportunities for individual counseling. And a lot of this relates to this question of developing rapport and trust. The fact that you need to be able to understand that this is a safe place, particularly in the age of social media and social media bullying and things like that. Sitting down in a group of my peers, some of whom may be in the same school with me, and having that be my main therapeutic contact may not work. We've heard from youth and from providers that there's a lot more need for individual for youth. And also we need to go beyond the focus on evidence-based practices and manualized interventions. Do things that interest youth and incorporate that into treatment. So outdoor activities, art therapy, music therapy, animal therapy, etc. Also, we need to think of services as enhancing motivation, because as I mentioned, youth haven't always faced the serious consequences of substance use like adults have. So this is where, rather than focusing services on, let's talk about everything that substance use has done to you and why you'd like to make a change, that's not going to work. We need to think of different ways to enhance motivation. And a lot of that is going to be a positive focus on what matters. Is that, the substance use is there, but there are other things that matters in terms of romantic relationships, skill building, vocational goals, things outside of substance use, using those as the carrots, so to speak, to really motivate change. And then also resources to facilitate parental and family involvement being very key. Things like if we just say, okay, come in and we'll have a therapy session with your parents. Well, think about all that means in terms of that means mom and dad have to take time off of work. They have to come with you to treatment. They might have to find childcare because I don't want your little brother to be in while we're talking about your substance use. There's a lot going on here. And one unintended silver lining of the COVID pandemic, I was just talking with a provider about this, was that telehealth really works for this. And that it's much easier for a parent to participate in a group session on the couch while little brother is watching TV than to have to come in. So that's a potential model. And then also this point on the top right, this idea of near peers. So throughout the substance use field of behavioral health, there's always talk of peer support, people who are relatable and things like this. However, if you go into a typical adult program, the peer will be someone who's in their 30s or 40s, again, someone who's faced the consequences. Yet what we need in the substance use field is someone who has the peer experience, yet is still young enough to be relevant. So this is why we call them near peers rather than peers. It's unlikely that a 16-year-old will be able to find a 16-year-old who could serve as a good peer. But how about a 21-year-old who, won't accidentally talk about MySpace the way I would instead of Snapchat or whatever? It's important to have that kind of thing. So near peers and finding those people and really honing their developments. Now, also, if we're going to talk about a system, we got to get a little wonky and have some data. Data is needed to make the case to policymakers, to communities, to the Board of Supervisors, to Sacramento, to Washington, that youth services are effective and provide them with information that's needed to facilitate quality improvement. So part of what we've looked at is, all right, well, what is it we want to look at? What is the data we need? Within the specialty addiction treatment system for adults, We have outcomes we measure that generally focus on substance use. There are other things that we would want to look at for youth as well, looking at treatment retention, reductions in stigma. Particularly what a lot of people have told us would move the needle in terms of motivating people is not so much these substance use issues, but rather increased success in other areas of life, both avoidance of the negative and achievement of the positive. So avoidance of the negative, if we can demonstrate that this program is reduced with less disciplinary issues, less justice involvement, things like that. And if we could also, on the flip side, and this is really where we want to go, show that these programs promote success, particularly when it comes to things like educational and employment outcomes. So that's kind of the overview of what we've done. So again, the blank check pie in the sky, this is what we need. Now the question is, how do we get there? And also something to think about is, can we use local communities, even if Sacramento isn't there yet, even if Washington isn't there yet? Can we as a school district, can we as a supervisoral district, as a SPA, perhaps move towards getting there? Now, our current work with CCF and the Youth Services Policy Group is continuing to expand on this, identifying resources and revenue streams to help, now that we have this vision, actually transform it into a reality. One interesting thing that had a lot of people hopeful was with Prop 64 marijuana legalization, that there was going to be a lot of funding for the youth system. Various reasons, the billions of dollars that were going to fall from the sky have not materialized. So we need to start thinking about what are ways that we could actually fund these better. We also need to advocate for changes in regulation to facilitate more youth-centered services, particularly the need for field-based services, because that's so critical once the pandemic lifts, hopefully. And also contingency management. Contingency management being a clinical intervention that uses incentives in order to help motivate treatment and get youth engaged. And I bring these two things up because these are A, things that are very important for youth, but B, unfortunately, given the microscope and the concern about fraud in youth Medi-Cal systems, these are both things where it's like, wait, you said you went to a park and you're gonna call that an hour-long session? I don't know about that. Wait, you're paying kids, you're gonna give a kid a stereo, an iPad? I don't know, that sounds fraudulent to me. So we need to think about ways to change the regulation and really facilitate the delivery of these services. We need to support the implementation of policy changes that can improve youth services, particularly at the county level, because that's kind of really where the action is at. And then we need to develop service systems that, again, don't just treat substance use in a silo. I think that a big issue we've had with behavioral health historically, and then particularly with substance use, is this idea that I can treat the substance use first and then treat the other things later. And it doesn't work that way. People are people. So we have to address their mental health and well-being. And a major thing the foundation is asking us at UCLA and APU to focus on for the next year is to think about other mental health and well-being services in ways that the needle could be moved in tandem with substance use in these areas. So that's what I got. And with that, I'll answer any questions or address any comments people will have. And I'll stop sharing my screen as well.
Great, thank you so much, Howard.
Thanks.
Any questions? All right, one quick item. It seems to resonate that we need that integration between mental health providers, substance treatment providers, et cetera, so that it is not separate entities, right? And one of the points regarding rapport building and trust establishment, if the clinician, therapist, what have you, has already established that, how to bridge that trust and report to a substance abuse center may be worthwhile. And I think that may help move things along. Yeah.
Yeah, absolutely. I think at the provider level, a big thing is that everyone is so focused on really survival at this point, but then also there's this concern about kind of scope of work and scope of practice. One area where I feel like there's a real has been a real missed opportunity is Mental Health Services Act prevention funds. The way that it's been narrowly interpreted as really just needing to focus on mental health, there's good reason for that. But I think also that then has closed the door to ways that other things that impact mental health could be addressed, such as substance use. So that's an area for potential advocacy and hopefully some regulatory change and ways to do this in a way that would work.
Absolutely, great. Thank you again so much. Appreciate your contribution. All right, so in the interest of time, we'll go ahead and move into one last segment for polling. Allow me to post that for you all. And here we are. And it reads, using the rating scale 1 to 5, 1 a little, 5 a lot, how helpful is it for you to receive the latest COVID-19 case count in your county? A little, somewhat, enough, moderately, or a lot? Couple more responses. Okay. All right. Great. Thank you for participating with that question. So it seems 42% of us indicate that it's very helpful or a lot in terms of being able to learn of the case count that's put out by the county. Excellent. Great. All right. One last question and then we'll end the segment. So using the rating scale 1 to 5, 1 a little, 5 a lot, based on your reactions to the pandemic, please rate how anxious you feel on a daily basis. And here we have options: a little, somewhat. Go ahead and make your submissions. All right. All right, great. Let's go ahead and close that out and let's see what we have. So it seems 38% of us indicate that we're anxious enough with respect to the pandemic and our reaction to it on a daily basis. Great. Thank you so much for participating in that segment. All right. So as we like to wrap up our town halls, we do a segment of call to action, and the items that you've heard from the speakers today and the information that was presented in the chat, one of which was the anniversary of the Voting Rights Act that is pretty significant and resonates to our current times and state of affairs. Very, very important. Please, recognizing that true change and formative change is really in the hands of the people, and that's very, very important, definitely. All right. And then also there may be additional information provided by the team in the chat feature in terms of resources and websites for information as well. All right. As we like to summarize in terms of the purpose, the intended focus is to join your community leaders as they share data and address underlying inequities as we've done. It offers you the opportunity to become informed of the past, understand the present, and move toward a transformative future. And it offers you the opportunity to serve as a change agent within your community. So again, imparting what you've learned, what you've gleaned, what you've picked up during these town halls to then take it back to your community is really the goal of these intended town halls. And just as a recap, I'll have it on here so that way it shows up in the recording segment, but this is ultimately how results we can then determine the ratings for folks that have participated in the polling series. Thank you so much for having done that. And in looking forward to what's ahead for our next town hall, the topic of discussion will be criminal justice system, wherein we will again look at the inequities embedded within the criminal justice system. That is scheduled for August 20th. As you did for this particular town hall, please be sure to register at Eventbrite and inform others to also be part of this very, very powerful endeavor that we've taken on. And in that regard, I'd like to extend a heartfelt thank you to the team, our Town Hall Series team, Jeff Farber of the Helpline Youth Counseling, Arlene Vasquez of Lakata, Irene Muro of Whittier First Day, Cecilia Reyes, Whittier First Day, Alicia Martinez Vargas of County of Department of Public Health, Diana Zuniga of County Department of Health Services, and myself. I appreciate the opportunity to have been part of this team, to have brought you a third segment of the Town Hall Series. Thank you, everyone else. We do have a little bit of time if anyone wishes to stick around and pose questions. Otherwise, does the team have anything?
I want to say thank you to everyone for their participation, especially our speakers, and for our commitment to change, and let's continue to move forward with this transformation towards equity. Thank you very much to everyone.
Yes, same here. Thank you very much to the speakers. Very amazing information. I really enjoyed all three speakers. Thank you so much.
Yeah, I just want to say thank you to everyone for participating, for joining in, for all of our speakers, and let's make the change happen.
Absolutely. Thank you, everyone. Bill and Howard, thank you as well for your contributions. See you all next time. Thank you.